Thanks, Greg. And good morning, everyone. Welcome. Thanks for joining us for our first webinar of 2023, From Pills to Fentanyl, Understanding the Opioid Crisis. And I think this is a great way for us to start the year, as you'll see with our upcoming presentation. Today's webinar is brought to you by the Partnership for a Drug for New Jersey and is being held in collaboration with the Opioid Education Foundation of America, NJ Cares, and the New Jersey Office of the Attorney General. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. Today's webinar has been approved for one EMT CEU and one AMA and ANCC credit, and we have no disclosures for this learning activity. And as Greg mentioned, the information on how to obtain that credit will be provided at the end. So I'm so pleased to introduce our featured speaker who is with us today for this important conversation and for launching this 2023 learning series, Dr. Lewis Nelson. He's the professor and chair of the Department of Emergency Medicine and chief of the Division of Medical Toxicology at Rutgers, New Jersey Medical School in Newark. He is board certified in emergency medicine, medical toxicology, and addiction medicine, and he serves as a longstanding consultant to CDC, DHS, and FDA, and works closely with several professional organizations addressing the medical and social consequences of substance use. So welcome, Dr. Nelson. Thank you for being with us today.
Thanks again, Angela. And I do want to thank the Partnership for a Drug for New Jersey and all of the people listed on the screen for having me here. I've had the pleasure of working with your organization and you before. And I think that the work that you do and the constituencies that follow you really do God's work in a way, just making sure that we keep the focus on what's important to ensure the health and well-being of all of our citizens of the state and of the country, in fact, particularly those who suffer from substance use and all of the peripheries that touch upon it. So it is great to be here. I think this is going to be a little bit of a different kind of lecture. It's the first of many, I know, for the series that you're putting on this year. It's going to be basic. It's going to try to cover some fundamentals. I'm not addressing deep clinical issues, I don't think, but I'm sure that if others out there have questions, I'd be happy to answer them into the Q&A session. I want to cover a little bit of history, some terminology I think is important, because really having a shared vernacular is very important to making sure that we communicate well. And one of the things I'm going to spend time at the end is to try to cover some of where we are miscommunicating, I think some of the misunderstandings. But in the middle, what I want to do, again, is provide those listening, and obviously it's a very diverse audience. Some of you are clinicians, some of you are scientists, some of you are lay people and lawyers, et cetera, regulators. I know there's a vast array of people. I want to make sure that we're all on the same page with understanding the principles of clinical pharmacology and toxicology as it applies to opioids. And that's sort of what I'm getting at with the title, to make sure we go from the prescription opioids to heroin to fentanyl and what's on the agenda going forward. I obviously have no disclosures. Nobody wants to fund people like me. As a toxicologist, I always look at the dark side of things, and that spooks people a little bit. But it helps us, and it's hopefully it'll provide everybody here with a little bit of context to what I see and what people that do the work that I see in emergency medicine and medical toxicology, which is the study of human poisonings, and addiction medicine, which I'm sure everybody's familiar with what we do. Some of this will be review. I can't help it. I just feel compelled to make sure we talk about some of these things. But I think we recognize that chronic pain has been and still is a big problem, something that's really developed in earnest since my youth to where we are today, where we're thinking about, tens and millions of people suffering chronic pain, many of whom are using or have used opioids in the past to manage that pain, leading to some extent in a prescription drug misuse epidemic, which in it itself is transformed to an illicit substance use epidemic. And I think we recognize that many people still use illicit substances as their primary entry way into substance use, opioid use. But we also have to recognize that many people who've, developed an illicit use disorder started with illicit or prescription drug use disorder. Recognize too that many prescription drugs are used illegally, so even the terms licit and illicit become a little bit complicated. I think when we say prescription drug use, I think we mean prescription opioids obtained through illicit use, meaning through a legal use. You can see the numbers down there. I think they're quite staggering. And I think the one that most really sums it up is this one that says that we're spending, or we spent in 2017, based on an analysis, over $1 trillion combating the opioid crisis that we've really been dealing with for the past 20 years in this country. As I promised, I wanted to just really define things, because people throw these terms around, and I think we have in clinical medicine, we have very specific meanings for these. And I will say that psychiatry and the more medical specialties disagree on some of the terms, but we do tend to agree more than we disagree, and I'll highlight that as I go through it. So abuse very clearly means use for the feeling that a substance engenders. Again, abuse, we're really talking about substances here, but there are other sorts of abuses and addictions that are not drug related, and people think about gambling and internet, things like that. So we're really talking about the same pathophysiology, the same brain effects, only what the inciting substances are do differ a bit. But abuse means use for the feeling that a substance engenders. A tolerance specifically means the need for more substance, in this case opioids, and I'll just say opioids just so everybody recognizes that this crosses the lines, the need for more opioid to get the same effect. It also means getting less effect from the same dose of an opioid you've been taking. It's the same meaning, just looked at from a different perspective. Dependence, and this is a term that we do differ. To a psychiatrist, dependence means addiction. To a non-psychiatrist, dependence means withdrawal upon cessation of a substance. Right. And it's very important with opioids, right? So you could be dependent and withdraw when you stop taking it, but you don't necessarily have to be abusing it. People who take opioids therapeutically for their pain, when they stop taking that opioid, are going to withdraw, and they are dependent upon it. Hyperalgesia is a relatively new term, probably maybe 15 years in the making, but something that's really important to understand if you want to understand chronic pain. Right. Opioids cause the pain that you're experiencing to get worse. That's hyperalgesia. It's an increased sensitivity to pain. Some people know the word allodynia, which is similar, but allodynia actually means spontaneous pain. Hyperalgesia means pain is more highly appreciated, but there's still some pain present. So what we're seeing, I think, in a lot of patients with chronic pain, not to say that chronic pain doesn't exist independently, but what we're seeing is people get started on an opioid, and then they develop sort of a vicious cycle of worsening pain due to the opioid and an increase in opioid dose to accommodate the pain, leading to increasing amounts of pain. So it is a problem that I think leads to a number of adverse consequences for people with chronic pain. And then, of course, there's the word addiction. And this is the one that's probably the most confusing to people, and they throw it out often to mean abuse and dependence, intolerance, hyperalgesia. But in fact, addiction is more than a pharmacological effect. Addiction is the wraparound that occurs from compulsive use despite harm. You can't stop using the medication or the drug or whatever it is, surfing the internet, and you lose your job, and you lose your home, and you lose your family. All of those adverse social consequences, psychosocial consequences, that is what makes addiction. Addiction can occur from any of these other routes, right? You can develop it from abuse or just from chronic pain. Once that crosses the line into social consequences, I think we really we describe that as addiction. All of these are a form of long-term use, which we really think about in the medical world as opioid use disorder, or OUD, and you'll hear that often. And OUD has very clear criteria set forth here in the DSM, many people are familiar with. And every substance has its own use disorder, but this is very clearly defined out for opioid use disorder. Regardless of the reason that you have long-term use or opioid use disorder, you are at risk for unintentional and sometimes intentional overdose, and often overdose leads to death. Death and overdose are two different things. Many people conflate the two. Overdose means you've taken too much and you've had an adverse consequence. Death is obvious as to what it means. Only really in the medical examiner world does overdose equal death. In the ED, we see people who overdose all the time and who don't die, right? But regardless of why you're using your substance, overdose can lead to death. And other adverse consequences. Probably surprisingly to many, we really don't know how much of an opioid it takes to develop an opioid use disorder, or any of those forms, whether it's abuse or dependence or ultimately addiction. That's one of the reasons we've pushed back so hard to try to reduce the amount of opioid that we give to people, both in the hospital. Of course, we're less concerned about in the hospital opioid use, but particularly opioids we prescribe to people when they leave the hospital or out in primary care or other practices, because we just don't know. We know that, there's probably, I venture to say 50 studies that show that about 6% of people on average, regardless of the reason they get started on an opioid, develop a long-term use disorder or opioid use disorder, right? 6% is not an inconsequential number, right? That given that we prescribe tens and millions of pills every year, you're talking about tens or hundreds of thousands of people who develop opioid use disorder. And we see that. And those of you that work in substance use, environments recognize that to be a big problem. And many people who, as we said, get started on an opioid, regardless of whether it's, just due to a friend giving it to them to try or a doctor giving it to them for their medical need, can go on and develop this. That 6% crosses all of those lines, right? And it may be higher, it may be lower, but that's just a good number to think about, because I think it makes a lot of sense. We know that has consequences, right? For the first time, if you look back to 2015, in pretty much all of our lifetimes, for the first time ever, life expectancy was shown to actually fall, due in large part to drug poisoning and opioid poisoning. And some of the other things you'll see listed here to the left of the line, dragging down life expectancy. Unintentional injuries, which undoubtedly includes some substances. Even suicide, I'm sure, does include that as well. Some of the others maybe not. We make great strides in treating diseases of the heart and malignant diseases like cancer, but we've really lost ground on substance use. Now, some of this has righted itself in more recent studies, which is great. But it's still very challenging to hear that we have had so much death and devastation related to opioids, that it's actually had a measurable effect on the population. I like to think about this because, as much as we like to think about death as an outcome, because it's really easy to measure. For every death, and this is approximations, you can quote me on it, but without any real scientific validity other than extrapolation from a lot of other data sets. For every death, there's probably about 10 people who are seeking substance use treatment at a treatment facility. There's probably about 25 ED visits and about 40 EMS activations. There's probably 100 people who are opioid dependent and are not yet seeking care, some of whom don't need to seek care because they don't really have addiction. They're just dependent because they take their medication for an appropriate reason. And then there's a good number, and the number that's proffered through the literature is about 625 people who non-medical use opioids. And non-medical here means anything from me taking your opioid because I have pain, which might be an okay reason, but it's not appropriate, to people buying opioids on the street, but not yet in treatment or dependent on that opioid. So this iceberg, so to speak, is really very telling about the consequences and why we're spending over $1 trillion a year on this problem. Now, of course, everybody recognizes that this is a problem that crosses all socioeconomic classes. I always like to just remind people that it occurs in wealthy, politically aligned and very conservative talk show hosts to more moderately positioned actors who have really no reason to have any worries in their life other than whether they're going to get their next gig in the industry, to the rest of us, to the regular people who go to the dentist or find a friend who gives us some opioid to try. So this obviously crosses all spectrum. And I imagine that many people on this Zoom have personal or very close personal connections to the substance use opioid in particular epidemic, but don't forget alcohol and all these other substances out there that really do not differentiate based on any sort of socioeconomic or educational racial, religious, political lines at all. All of us are affected, which is why it's so important that we address this as a community and as a population. All opioids are really exactly the same. And I think that's a really important thing to understand, because a lot of people vilify certain opioids like heroin, but in reality, heroin's just another pain med. It's just another opioid, right? And I give you some structural examples up there. And to those of you that think chemically and have training in chemistry, that you can probably differentiate these. To many people, this kind of looks like some of those games you play as a kid where you try to find the differences between two different pictures, and there's going to be a couple, and you got to figure them out, and you got to look pretty closely to see the differences. Obviously, heroin compared to morphine, there's a very dramatic difference based on those two acetyl groups that are linked on the OHs that you see on the morphine, and you see these two carbon molecules attached to that side of the heroin molecule. That's why heroin's name is diacetylmorphine, because it's basically just got two acetyl groups attached to those hydroxy groups on morphine. It's a little more subtle with the prescription opioids that I provide structures for down on the bottom, but recognize that those changes in the structure have marked changes in the clinical effects, right? Or I should say, in the clinical effects are the same, but the degree of clinical effect is a little bit different. All opioids relieve pain. All opioids can cause euphoria, and all of them, and most importantly, can cause respiratory depression. The areas of the brain that those things occur in are quite different, right? Pain relief occurs in the cortex, the outer layer of your brain that you see when you look at a brain. Euphoria occurs more internally in areas like the limbic system, and other parts of the brain that you can't see from the outside. And respiratory depression occurs in the medulla, or the brainstem of the brain, which is the bottom part that sort of juts out into your spine. Right. And why that's important is because what the opioid clinical effects are determined by is in part the things that you see listed there, which I'll spend a second talking about, but also what parts of the brain that opioid can access most readily. So if it gets into the cortex, you get better pain relief. If it gets into the limbic system, you get more euphoria. If it gets into the medulla, you get more respiratory depression. Some of this is rate related, some of it's dose related, some of it's based on lipid solubility, some of it's based on how tightly these drugs bind to the receptor once they're there. Some is based on dose, right? Low dose versus high dose. The low dose of all opioids is fairly safe, at least from an overdose perspective, but a high dose of all opioids, and there's none that are safe if you take enough of it, can kill you. Potency is related to dose. Potency really means how much of a dose, what number of milligrams do you have to take per kilogram of body weight to have a given effect? And we're going to talk about this more with fentanyl in a moment, but potency has a lot of meanings to a lot of people, but what potency really means is how many milligrams or how much weight of a drug do you have to take to have a given effect on you. And that effect could be pain relief, it could be euphoria, it could be respiratory depression, or something else. And dose rate is important too. That is, how quickly did that dose get into your body? Right? If I give you a gram over a day, it's very different than giving you a gram over a minute. Right? And dose rate is very important when it comes to determining clinical effects. Many have seen this ad or other ads, and at some level you can say it's a little sensationalistic, right? Because I don't think most of us think this way, but recognize that oxycodone, hydrocodone, and heroin are all exactly the same. They're all equally safe. They're all equally dangerous, right? As long as you take the right dose, there's really no reason to think one is a bigger problem than the other. However, we know that heroin has a lot of social implications and social uses that are not necessarily medical, but there are parts of the world where heroin is used as a pain reliever. And given in the right dose at the right rate by the right route, it's no different than any other drug. Right? It does raise the question, which we're not going to discuss here because it's highly politicized, is why isn't heroin legal? I'm not advocating for heroin to be legal, but it does raise that question. We've chosen heroin to be illegal, and that's fine. And it should be, I think. I said it wasn't going to get political, but it does raise that question, because why isn't oxycodone considered the same way we consider heroin? Isn't it just legal heroin? Well, at some level, it is. When used by the right/wrong route at the wrong dose, it becomes no different than heroin, honestly. So a little bit of the history, and I think everybody's recognized this, but back when I and many of you were children, nobody used opioids chronically for pain. That really changed back in the early to mid 80s when some data came out suggesting that chronic opioid use might actually be beneficial. And what they defined chronic was more like measured in weeks, not measured in years. Of course, that snowballed through the 90s when we saw the Joint Commission, the American Pain Society, and others come out with and the VA, in fact, come out with the fifth vital sign movements. We know that shortly after that, OxyContin was marketed in 1996, which clearly changed the entire dynamic of how opioids are viewed. Subsequent to that, Joint Commission weighed in on pain management standards and how we have to address pain. Later down the road, CMS based some of its payment models on patient satisfaction, which of course was not directed at opioids, but pain relief was part of that. And clearly opioids do work to treat pain despite all of their consequences. You could see that many remember that Purdue was guilty of misbranding OxyContin, saying that it had a low risk of addiction, which clearly wasn't true. They reformulated in 2010. And I think it's important to remember 2010 as we move on to the next slide. But 2010, they reformulated OxyContin from being something that was a pill that contained 60 milligrams of oxycodone, which is what's in OxyContin, that could be crushed and all the oxycodone removed. Remember, a Percocet tablet contains 5 milligrams of oxycodone, to one that couldn't be crushed. Right. In 2011, the IOM report came out talking about how prevalent chronic pain was, which further increased the reliance on opioids to treat pain. Now, fast forward a decade later, and we see what's happening now, where we've recognized that what was going on back then was in fact a problem, something we had been talking about pretty loudly, but not getting a lot of traction in. I mean, there is certain satisfaction in being proven right, but obviously a lot of destruction's been left in our wake. And you can see now that Purdue essentially has kind of gone away, left to be a foundation that's trying to pay off some of its debt. Why I said 2010 was important is, remember, that was the year oxycodone was reformulated to be less abuse prone or tamper resistant, depending on what word you like. You can't just crush with a hammer and take the oxycodone out anymore. That happened to be the same year that we started to see an inflection in the rates of heroin use, right? The brown line. Right. Now, whether it's coincidence or if they're related is unknown. We also know that in 2010, the purity and affordability of heroin actually got better. So heroin got more pure, it became more intranasally usable. You didn't have to inject it as much anymore. And in part because of the concentration of heroin went up. Some say potency, and that's probably, as I mentioned earlier, not the right term, but rather the amount of heroin in a sample went from 5, 6, 7% to 10, 12, 15, and up to 20, 30%, meaning it was more easily put up your nose and not necessarily put in your vein. Or whether it was people who could no longer get their OxyContin, et cetera, from their prescribers who switched over to using heroin. And that's an existential question. I don't know, we really know the answer to. It's probably both. Right. And then you can see in 2013, another inflection in the death rate related to other synthetic opioids. And of course, as important as tramadol is and methadone is in the world of synthetic opioids, the 800-pound gorilla, of course, is fentanyl and all of the fentanyl analogs, which we're going to spend a moment talking about. But really, we started seeing that in earnest in 2013. There have always been little pockets of fentanyl clusters here and there, China White, Tango and Cash, this and that. But really in 2013, it started to infiltrate itself into the generic heroin supply. So when you today buy heroin, of course, almost everywhere in the country, there's little to no heroin in that sample. It's pretty much all fentanyl. Fentanyl is an opioid, right? It's no different than any other opioid we talked about earlier, except that it's made synthetically. All of the other opioids, you can see their structure, look just like morphine or another derivative from the opium poppy. You take that, you change it chemically, and you have oxycodone, hydrocodone, or any other opioid. Fentanyl, I didn't put a structure on here, I probably should have, looks nothing like that, nor does methadone either, for that matter. But yet it binds to the opioid receptor potently, meaning it takes a tiny dose to have an effect. A typical dose of morphine might be 8 milligrams that we give somebody clinically. A typical dose of fentanyl might be 50 micrograms that we give somebody. Remember, a microgram is 1,000-fold less than a milligram. So you're talking about potencies of 100 times-ish that of morphine. Right? Potency meaning how many milligrams per kilogram do I have to give you to have a given effect? The effect we're giving to people in the hospital, of course, is pain relief. Fentanyl is lipophilic. And why is lipophilic important? Lipophilic means it dissolves rapidly into the fat that is your brain. One of the reasons that they add acetyl groups to morphine to make it into heroin is because it becomes more lipid soluble, lipophilic. Right? Heroin gets into the brain much more quickly when put into your body than morphine does, which is why dose rate, the rate at which that dose enters the brain, is much more quick, much more rapid with heroin than it is with morphine, which is why nobody abuses morphine, which is why the cartels go through the process of taking morphine that they get out of the poppy and converting it to heroin. Right? If they didn't have to do that, I can assure you they wouldn't. But if they went on the streets and tried to sell morphine, nobody would buy it. So they have to make it more lipophilic so you get a more rapid onset when it's administered into your body. More euphoric, more rapidly enters the brain, more rapidly gets into the parts of the brain associated with reward, and more rapidly do you feel good. However, at the same time as getting into the good parts of the brain to make you feel good, it's also getting into the medulla and making you stop breathing. Right? And we know that when you die of an opioid, the only reason you die is because you stop breathing, assuming you're not driving a car or doing something else at the same time. If the opioid kills you itself, it does that through respiratory depression. It's because opioids suppress the function of the brainstem of the medulla, which means your breathing slows and stops. Obviously, the more you take, the more your breathing slows and stops. So a little overdose, which is what most people take, doesn't kill them. In fact, most people who take opioids every day overdose. If you assume a dose is a dose you take for pain relief, they take too much, right? They overdose, but most of them slow their breathing but don't stop breathing. But if you take too much, it's easy to stop breathing and die. At very high rates of infusion of fentanyl, you actually get muscle rigidity, which might lead to some of the death, and particularly the rapid death we've seen in some of our patients. A little unrelated to today's discussion, but I want to just say it, is that even though fentanyl is very short-lived when you use it clinically, I give it to you in an hour later or better. When you use it when you use it repetitively, because of its high lipid solubility, it stores itself in the adipose tissue of your body or fat, and then it leaches out over time, which is why the dependence that you develop from fentanyl, your opioid receptors are continuously bathed in fentanyl. The dependence you develop is much greater than it is with a drug like heroin, which is up and down in terms of the blood level. Heroin goes up and then it kind of stays moderate even after you stop using the drug because it's leaching out of the fat in your body. Again, to just show you a quick picture here of some confiscated samples, and many of you have seen these sorts of data, you recognize that the majority of the heroin supply in New Jersey contains fentanyl. In fact, there's virtually no sample that contains only heroin. Of course, we can't ignore things like xylazine, which are increasingly prevalent in our heroin supply, and I say heroin in quotes supply in New Jersey, particularly in southern Jersey and the Philadelphia area, but all across New Jersey, we're seeing xylazine. And xylazine itself probably has implications we have to think about. How much it impacts the risk of overdose and withdrawal, et cetera, is yet to be determined, but certainly it's a concern that we all have to pay attention to. Now, recognize because the dependence that you get from fentanyl is so much deeper than it is from heroin, getting people into treatment is much harder. Like getting people onto buprenorphine is much harder. Getting people to quote unquote detoxify and to stop, a term we don't really use in opioid addiction treatment, but to stop using the opioid is more difficult because their dependence is just so extreme, because the drug is so lipophilic and so potent and so able to get into the parts of the brain that are associated with pleasure. It's so difficult to stop using it. This is just a graphic version of sort of what I showed, but it does let you see that of the fentanyls, and there are many fentanyl derivatives, which are listed out on the right side of the image, the vast majority of the supply still contains plain old fentanyl. Now, all of these derivatives are similar to fentanyl, but different. Some of them are more potent, means it takes fewer milligrams or micrograms to have an effect. Some of them last longer. We don't know enough about most of them to really say anything credible about them. But what we do know is they basically are all fentanyl, right? Because of their potency, because they're so highly potent, remember, 100 times that of morphine, 50 times that of heroin, it's really hard to dose them. And one of the reasons we see such great problems with the fentanyls is that the dealers have trouble putting together an appropriately formatted sample for somebody to use. Just as a nice example, I took off the internet, you can see a lethal dose of heroin, and compared to that of fentanyl, remember 100 times the potency, so it's about 100th of the amount, or 50 times the potency of heroin, so about a 50th of the amount. Carfentanil is 100 times the potency of fentanyl. So there's 1/100th of the amount of carfentanil it takes to have the same effect that you get from a certain dose of fentanyl. Why that's a problem is not because carfentanil is a problem. If you dose carfentanil properly, it's not an issue. It's just so hard to dose properly because think about the amount, there's a pinhead amount of a drug that's lethal. So you have to take sub-pinhead amounts of drug safely, really challenging. Just put in a graphic form here. This is a safe dose. And I put safe in quotes because I'm not suggesting people should be doing this, but there's no doubt you can safely use carfentanil, right? If you mix them, you can create equally effective safe doses. You just have to reduce the amount of fentanyl if you're adding carfentanil. You have to reduce the amount of heroin if you're adding carfentanil, right? If you give a little too much and you don't reduce it properly, you could see how it becomes dangerous. You've now overdosed. Right? You put a little too much carfentanil in your fentanyl or heroin supply. You take a little too much carfentanil because it's so hard to dose adjust. And of course, to the next stage, it's easy to overdose and die because it's so hard to control how we use these ultra potent opioids, whether it's fentanyl or any of its analogs, or nowadays we talk about the nitazines, which are another form of opioid that's synthetic and has similar effects to heroin or to the opioids. Of course, we're talking about intranasal, we're talking about intravenous drug use, but remember that much of the prescription, or I should say of the counterfeit prescription opioids that we get on the street contain fentanyl. To remember, that's how Prince died. He was perceived to be a hydrocodone preparation. Of course, it contained fentanyl. He didn't know. There's no way to know. And he was, of course, found dead with a boatload of fentanyl in his stomach. He'd eaten the pill, thinking it was a hydrocodone tablet. And of course, it contained fentanyl. By whatever route you take fentanyl, it's still more potent than any of the other opioids we talked about. Hard to tell fake from real. All right, this is something I've took off the DEA website, but you can see many examples of this. These pills are pressed, of course, to look exactly like real pills. That's the way it has to be. What have we done about it? Well, we spent a lot of time trying to limit opioid initiation through the use of pain guidelines, particularly multimodal analgesia, you can see our guideline on the right of the screen, trying to withhold opioids till the third or later stage of pain medicine management. Using multimodal analgesics. That includes nonsteroidals, which is ibuprofen, for example, or using acetaminophen or other agents to take the edge off pain. Not promising a pain score of 0 in people, but telling people we're going to get their pain down to a manageable, a tolerable level. I've taken up the sort of the mantra that we should keep opioid naive patients opioid naive as long as we can whenever possible. It doesn't mean if you come in with an opioid requiring pain syndrome, you shouldn't get it. But it means that we know that some of those pain syndromes don't need it. Ankle sprains would be a nice example. Nobody should have an ankle sprain beyond an opioid, right? They should get an ACE wrap put in their leg. They should get some ibuprofen, and they should give it a couple of days till it gets better. We've talked a lot about using opioids safely through the way we use electronic health records, prescribing limits that have been described by the state, put into our health records, order sets that kind of lead you down a pathway to safe opioid prescribing. We've nudged prescribers through various processes, including comparing them to how other prescribers are doing, so they get a sense as to where they are in terms of the opioid prescribing hierarchy. Patient education, of course, is very important, as well as prescriber education. And many people recognize the use of prescription monitoring programs to monitor patients as well as prescribers and how they're doing in terms of what drugs they're getting or what drugs they're prescribing. We've also taken a harm reduction approach. I think very important. Keep calm and carry naloxone is one mantra that many use. I think bystander naloxone is critical. It's got to be out there. You can't give it to yourself. Somebody else has to have it to give it to you. Obviously, if you need it, you won't be able to give it to yourself. But what's really important is that you can reverse somebody's overdose. But if you don't get them into treatment, you're not really saving their life, because I can assure you that they're going to go out and overdose again. And that data has been very clearly shown by some colleagues of mine up at Mass General, where they looked at both ED and EMS naloxone use administration. And if you look that within a year after ED discharge, 5% of people are dead, most of whom died of an opioid overdose. And if they discharge from the scene and don't make it to the ED after getting naloxone from ES, 15% of them are dead in a year. You'd like to believe that in part, the reduced death rate from going to the ED is getting engaged in treatment of some sort. But it really does remind you that treatment is what saves lives. Naloxone has an important effect, and I've been a big proponent, but you got to get them into treatment. It doesn't really prevent them from overdosing again. Other harm reduction efforts people looked at, many of you are probably involved with things like needle exchange programs or testing strips. Very important, with the understanding, of course, that all of our heroin contains fentanyl. So the use of a testing strip seems somewhat limited currently. Maybe there's a better role in its use for cocaine, which does seem to have a measurable amount of fentanyl in it when you buy it on the street. And despite the sensationalism surrounding cannabis containing fentanyl, I'm not sure there's a lot of credible evidence to say that that's actually there, nor would it make sense to put it there from a business model perspective, right? You can see where it would work well with cocaine, but people who use cannabis typically don't have any safeguards against overdosing on fentanyl, so it doesn't make a lot of sense. Of course, we put into place a lot of strategies to get people into and maintain them in addiction treatment programs, screening in the EDs and other venues, reducing barriers to getting care like telehealth, the use of recovery coaches or peer navigators to get people into and maintain their connection to their treatment program. And of course, we have a lot of good medications that we use. By far the best pharmacotherapy against a use disorder is for opioids. We have very little for alcohol. We have virtually nothing for cocaine, amphetamines, or most of the para addictions like gambling. I want to spend a minute talking about a couple of controversies, and then I'm going to open it up for questions. I think these are really important, and I hope I don't come across as too strong or opinionated here, but I am fairly opinionated when it comes to these issues. And I'm happy to debate them in the Q&A, or I'll provide you at the end with my email address, and I'm happy to engage in a conversation about all of these. I could tell you that the problem with many of these, if there's anybody in the media out there, has been the way these things are put forth in the media. Often they take a statement from somebody who may or may not be qualified to make it, and they interpret it in a way that probably is not optimal, and then they put it out there as sort of, as many of you know, we tend to view the media as gospel, as incontrovertible as data. Of course, it depends on what news station to watch, et cetera, for what truth is. But that being said, whatever station you're watching, you tend to rely on what the media says. So it is an example. There's a lot of people out there who say naloxone doesn't work to reverse fentanyl. That is absolutely not true. Naloxone works very well to reverse fentanyl. If you give a regular dose of fentanyl, a regular dose of naloxone works. If you take a massive overdose of fentanyl, you might need more naloxone, undoubtedly, right? But that would be true if you took a massive overdose of heroin too. It's a competitive antagonist. It binds to the same opioid receptor that the opioid binds to, and it knocks it off. That's all it does. It's opioid-like in structure, but it doesn't stimulate the receptor. Right? It has a high affinity for the receptor, so it binds to it and can knock off the opioid, and it has a higher affinity than all of the opioids pretty much that we see, and it will definitively knock fentanyl off the receptor. But because there's so much fentanyl in some of these patients who overdose, you sometimes need a little more. And sometimes you need to give it a second time, because as I mentioned earlier, fentanyl lives in the fat and leaches out. Naloxone lasts for an hour, but if the fentanyl doesn't fall in that hour because it's leaching out of the fat, you might sedate again. So you sometimes have to give a second dose. That is normal. That is not super potent drug. That is not failure of naloxone. That's just plain old pharmacology. So naloxone works fine. Remember, the endpoint of naloxone is not waking up and leaving the scene. The endpoint of naloxone is breathing. It's all you need to do for your person, your victim, your patient, is make them breathe. You can breathe for them mouth to mouth, or you can give them naloxone and make them breathe. They don't have to wake up. In fact, I don't want them to wake up. I want them to come to the hospital and wake up there so I can get them into treatment, or at least talk to them about getting into treatment. Another sensationalist headline we see a fair amount are things like this, and there's even more egregious ones. You'll sometimes read like enough fentanyl to kill the entire country of the United States or the entire world in a bust. Right. Now, recognize that mathematically that works out. If you believe, and it's probably reasonable to say that 2 milligrams, 2,000 micrograms of fentanyl will pretty much kill everybody who gets it. So if you say you got 1,000, if you got 1,000 milligrams, you could do the math to say if 2 milligrams kills a person, then, you know, if you have 1,000 milligrams, it'll kill 500 people. Right? And you can extrapolate that math out to 4 million if you want. However, you can't get that dose into 4 million people. So while this is a true mathematical statement, the headline is a little bit misleading. It sounds like we were really at risk of 4 million people dying. And clearly, that is not going to happen. Perhaps the most controversial, but the one I feel most passionate about, and something that really troubles me, is what we're seeing with officers, mostly officers, but it's not only officers, but I'll use officers as an example, and please don't take it the wrong way, because this happens to nurses and doctors and people at carnivals and all over the place, but it just, the media latches onto the officer scenario most often. An officer pulls somebody over and sees some fentanyl in the trunk or on the seat, and suddenly gets dizzy and collapses. Often they're breathing fast and their eyes are open and they're having palpitation, they're sweaty. But that is not what an opioid overdose looks like. There is no practical way for a drug to get from a car seat into an officer without that officer picking it up and putting it into their body. Even touching it will not get it into your body quickly enough to get sick. In fact, it probably won't get into your body at all. It just doesn't have that property to get in through your skin unless properly formulated in a patch, which we sell for medicinal purposes, and put on your skin. And even in the patch form made to be put on your skin and absorbed, it still takes hours before there's any measurable fentanyl level in your body. So what we're seeing here is what I like to call the nocebo effect. I hate to sound too, people don't like the term anxiety or panic because it's not necessarily that, but it's an expected normal human response with stressful situation, analogous to the placebo effect. We know placebo effect means I give you a red pill that's going to make your headache go away. That red pill contains sugar, but lo and behold, your headache goes away because you believe it's going to go away. Well, the nocebo effect is the opposite. I give you a red pill that's going to give you a headache, but the red pill only contains sugar. But lo and behold, you get a headache because you believe you're going to get a headache. And I think we've so primed our officers and others for this to be a problem that we're misattributing the problem to the fentanyl. That has implications, right? Implication one is we've had people charged with assaulting an officer for something that they didn't really do. Now, I'm not advocating for people carrying fentanyl, but certainly that doesn't really amount to attacking an officer, assaulting an officer. We've seen and heard of people not getting the care they need in an overdose scenario because people are afraid of going near them and giving them CPR or giving them naloxone because they're afraid they're going to get poisoned themselves. That's not good. These people who are collapsing of opioid overdoses are our brothers and sisters and family and friends, and they need the help they can get from our officers and our bystanders and everybody else. And we can't let them think this is too dangerous because it's not. I'm not trying to pull the wool over their eyes. It's just not dangerous. It's just that simple. And of course, I want to spend 1 second talking about rainbow fentanyl. There's been a lot of speaking about this, and there's really no data to suggest that these pills were targeted towards children or anybody else. Right? This is just more likely than not a marketing ploy that we've seen. Every heroin sample comes stamped with a label, whether it's the Playboy bunny or the Mercedes-Benz symbol or anything else, just like these are stamped to look like pills, oxycodone in this case, but containing fentanyl. I don't see any reason, any business model, et cetera, would allow you to believe that that's what's actually happening. So to summarize, and I'm going to open up for a couple minutes of questions. I'll let you read this, but I'll cut to the chase. the thing that's most passionate that I believe in is be careful about reading health books, to quote that Mark Twain made many, many years ago. You may die of a misprint. Right. Be careful what you're hearing about. Understand how these drugs work. Understand the pharmacology and toxicology of things, and you'll be able to think outside of the box a little bit. You'll be able to contextualize what is reality and what might be a bit more fictional. So I'm leaving you there my email address. If you're interested in conversing about this or yelling at me, please feel free to do so. I'd say you can follow me on Twitter, but I don't really tweet much, and I don't check it very often. But you're welcome to do that. Okay, so with that note, Angela, I'm ready to see if anybody has any questions they'd like to discuss.
Oh, great. Well, thank you so much. Before we go to questions, I'll give you a second. I know there were quite a few questions about how to access naloxone and where you can get it without cost. And so we'll make sure that we put a link to some harm reduction information on some groups that are distributing it in the post webinar email. So anyone who wants to connect with any groups or get a training for your community organization, you can find that information. We'll make sure we put it in that email that you'll get post event. So just wanted to make note of that before we get started. I know we also have, we're also pleased that you've been with us to kick this off, this 2023 learning series year. And we have a number of events coming up. That information is going to come up on your screen in a few minutes, as well as a poll. And I would appreciate anyone who is on with us to give us some feedback in that poll. But we do have a number of questions that came in, and let's get started with, there were some questions about who should be prescribing for pain situations, and how do we look at that connection between that prescribing and pain? Should it only be pain management specialists? Is it something that, we should only be looking at for long-term chronic pain? Can you speak to that?
I mean, there's no way you should only be pain specialists. Absolutely. I mean, there's not enough pain specialists around to manage pain. Everybody should be prescribing pain medicine. Everybody that's qualified. I mean, physicians, nurse practitioners, dentists, all the people who are allowed to do that. Undoubtedly, I think that we need to sort of right size the indications, the doses, the durations that we're giving. The biggest problem that I think we see with opioid prescribing isn't what we give or how much we give it, but it's how long we give it for. In the first iteration of the CDC guidelines, which I was a panelist for, I know there's a lot of people that have pushed back on those. We recommended, based on some real data, that nobody get more than 3 days as an initial dose. I think that people felt that was too restrictive. But, New Jersey has its rules that I think recommend up to 5 days on that first dose, which seemed very reasonable to me. And there are nice data from the CDC and others that show that the longer the initial prescription, the higher the risk of developing use disorder. So I think everybody should give it if they have the right indication. The indication can't be a sprained ankle. Clearly, we've learned a lot about what we should and shouldn't be using it for in the past 20 years. And if it's targeted properly and dosed properly and the duration is right, I think we need to use opioids. Nobody's arguing opioids shouldn't be used for pain. I think they're absolutely critical, but they have to be treated with the respect that they've earned for all of the consequences that they cause.
All right, great. Thank you. And can you talk about some options for discharge planning for patients who have opioid use disorder? We have some questions on that from.
Can you say that again? I'm sorry.
Some options for discharge planning for patients who have opioid use disorder who come through.
Yeah, I mean, we and everybody does it a little bit differently. It depends on the system you work in, but I think that we have a system where we use peer navigators to get them into a clinic that we have, or a primary care setting that we have, or sometimes to outside organizations. Many of our patients will try to get into, directly into outside treatment programs. There are many treatment programs in the state who are willing to accept our patients. A lot of it depends on, the payers that they have and the connectivity they have to the community and where they live and this and that. The most disenfranchised patients, of course, have the most difficulty getting into care. There are different approaches to managing substance uses in the outpatient world. Many of our programs are abstinence-based programs, which don't believe in using evidence-based medicine. That's fine. That's their decision. If patients want to go that route, that's very legitimate. They just should understand that the evidence does not support abstinence-based treatment as much, at least for opioids. And for other drugs, it's very different, as it does for medication-based treatments, what we now call MOUD, or medication opioid use disorder, buprenorphine, methadone, and naltrexone. But again, there's no right answer. The most important issue is that somebody gets treatment. I have my preferences, but I'm one of many, and I won't argue that others have different opinions that are very strongly held, and I think they believe them, and I think there's some credibility to some of them. That being said, getting yourself into some sort of treatment is very important. The one thing it's bad to do is just to say, you've overdosed, get out, have a nice life, go find treatment. Right? Unless they have a really strong family or friend who's going to do that for them, they need our help to do better. We don't have the best system in this state, but we don't have the worst system in this state either. We do put a lot of resources into outpatient addiction treatment. It's still hard to access because of people's socioeconomics and other things, but I think we do need to make sure that we provide people with a connection, not just a promise or a hope that they're going to get care.
Absolutely. And just mentioning you're based in New Jersey. We have a lot of attendees who are from outside New Jersey. So just wanted to make mention
I think
New Jersey.
Every state does it a little bit differently. Some states are better and some states, and it's not hard to believe that would be true. Yeah, and I am talking from New Jersey perspective. That's where I work. I did work in New York, in the same issue in New York. It varies very much on where you live in the state, who you are, et cetera, et cetera.
So you talked about some myths. Can you speak? Are you seeing fentanyl mixed with marijuana? We have some questions on that.
I have my medical marijuana is a little bit paradoxical. So I do not think that there are any proven indications for medical marijuana for medical therapies. Certainly not anywhere near the degree to which it's being proffered out there now. I think that I'd rather somebody be on cannabis than an opioid, but I don't know that cannabis is necessarily the answer. I mean, this has been studied. It's not shown to necessarily have the beneficial impact that was expected when people started talking about this. I'd love to see evidence showing that cannabis works. I'm certainly not against doing the science to show that it's helpful, but currently, with very few indications, that FDA has already approved, there's very limited data to actually support, other than sort of a general well-being feeling that you get from cannabis, that there's any direct medical benefit.
Yeah,
now, when it comes,
question goes specific. I'm sorry if you were going to go there.
okay.
Question goes specifically to similar to like the idea of the rainbow fentanyl. It's something we need to be aware of. Are you seeing in the emergency setting people who have used marijuana that has been laced with fentanyl?
Oh, no. I honestly, as I said earlier, I would need to see real data that show that people are actually putting fentanyl in cannabis. I find it hard to imagine from a business perspective anybody. First of all, the two lines of use are somewhat distinct. The population that use them, the population that sell them, they don't really overlap as much as the cocaine and opioid population do. I don't think that the people using cannabis really would want to use fentanyl. That doesn't mean it doesn't happen. I just haven't seen anything. I'm sure there's somebody on the call that has data and they'd be happy to share it with me. And I'd love to see it, but it just doesn't make intrinsic sense to me that there'd be a lot of overlap between the two. I have not seen anybody. We have seen consequences of excessive cannabis use. Of course, we see a fair amount of hyperemesis syndrome associated with cannabis, which is an acute problem. And there are other long-term implications of it, but that's probably off the topic of the question you were asking me.
Well, we're coming to the end of our time. We have about a minute. Is there one last comment or thought you would like to, or you think is most important to leave with our attendees?
Yeah, I mean, I spent a lot of time talking about an understanding of the fundamentals of opioids. And obviously, some of what I said is going to be controversial to many. We all have, just like if you had other people talking to me, I would disagree with them. That's nice. It's good that we have that, and we want to have that sort of discourse. And I'm sure, hopefully, I'll get some emails or some comments, and it's going to be civil and professional, and we'll have a conversation about it. I come from a position of emergency medicine, addiction medicine, and medical toxicology. I'm not a pain doctor. You know, I don't do that. I take care of a lot of people with pain, and I take care of a lot of the adverse consequences of pain. I'm certainly willing to have that conversation, but I think we have to recognize that this is a community problem. It's not an individual problem. We have to address it as a group. But in order to do that, we really have to have a common understanding of the reality of a lot of these things, not just what we'd like to think it is or what others tell us it is. And I think understanding these basics that I hope I imparted to you today, which pretty much are factual, I think scientific, factual pharmacology and toxicology. I hopefully people walk away with some better understanding. Again, to have a conversation. You know, I'm not taking away other people's opinions.
No, and I think that that you hit all the marks on everything that we wanted you to discuss today, and really gave us a great understanding of what is happening and what we're seeing and why. So I thank you again for being with us, for sharing the information, and for your time today.
Thank you for having me, and thanks to the audience for participating. I appreciate it.
Yes, and thank you to our audience. Once again, there's information on the upcoming February event on the screen, so you can go ahead and register for that now. We've also included some information on some different toolkits and other information that you can access in the chat. And we hope that you'll join us throughout this year for the 2023 Knockout Opioid Abuse Learning Series. So thank you so much, and have a good day, everyone.